Thank you. Thanks. So we're going to talk about seizures and their treatments. It's a lot to do in an hour, so I kind of jammed it as much as I could. I'll have to go over some things kind of quick, so I can't get into too much detail on certain things, but just trying to hit the highlights of what to look for seizures, what to think about, how to define them, how to what are you dealing with, and then what do we do to treat them. So when you think about Angelman syndrome, it's mainly, if you've gone to the research meetings or we're at the scientific symposium, we're talking about the UBE3A, it's really only abnormally expressed in the nervous system. So Angelman syndrome is mainly a brain syndrome. It's psychiatry, neurology, neuropsychology, sleep. The one kind of additional system that's involved is GI, but it's really the nerve inputs to the gut and the tone of the muscles in the GI tract. So it's also kind of neurological. And the other things we see besides all the neurological and psychological stuff we've been talking about, we see orthopedic issues, which are often largely due to neurology issues, and also ophthalmologic, so eye problems, which are mostly eye alignment issues, again due to decreased tone in the eye muscles. So it kind of all kind of traces back to the nervous system when it comes to Angelman syndrome. So with all that in mind, we're going to focus on the seizure piece for this session. And just kind of a basic overview, we'll go over the seizure types and epilepsy syndromes, kind of just to get the definition straight, because sometimes that's really confusing. And you hear this term and that term, and it just all kind of runs together. Talk a little bit about status epilepticus and non-convulsive status epilepticus. Talk about epilepsy specifically in Angelman syndrome. A tiny bit on the EEG of Angelman syndrome, a little bit about something that we've been seeing a lot more of that's really come up a lot is non-epileptic myoclonus, so not seizure, but looks like seizure, and I think it's an important thing to add for this session. And then at the end, treatment options. So just to get the kind of definition straight, epilepsy traditionally is defined as 2 or more unprovoked seizures. So unprovoked meaning it's not from meningitis or getting hit in the head or some crazy event that isn't expected. So 2 or more seizures, that's technically epilepsy. So you can have 2 seizures ever and it's epilepsy, or you can have hundreds a day and that's epilepsy. Epilepsy just means that you've had more than one and it's a pattern. That's been kind of modified lately to say if you have 1 seizure with an abnormal EEG, we can call that epilepsy. So those are the 2 definitions. So we've had families that have come in and said, no, we don't have epilepsy, we have a seizure disorder, but that's what epilepsy is. It means you have more than 1 seizure. Seizure types describe the actual seizures. So when you have seizures, there's we call them focal seizures, we call them Atonic Seizures. We'll go through that whole thing. But that describes the actual seizure itself, whereas an epilepsy syndrome is different from a genetic syndrome. It's not Angelman due to this genetic mutation or Rett syndrome due to this genetic mutation. It's just a way to kind of classify the epilepsy, and it's the seizure type and some EEG findings and also kind of developmental progress. You can roll that all into one. You can get specific epilepsy syndromes, and sometimes it gets confused that that you can hear a syndrome type and think it's a seizure type and vice versa. So just trying to kind of keep things straight. When you think about seizure types, there's 2 main categories. One is focal. So a focal seizure is one that starts just in one part of the brain. It can spread, but it just kind of starts in one area. Whereas a generalized seizure is kind of the whole brain going at once. So I don't know if I have a pointer, but you can use the mouse. Is the mouse up there? No. But if you look at that top line, so you don't have to understand EEGs really to know that if you look at those 4 lines, that's kind of the electrodes going from the front to the back of the brain. If you look up to at the top, that's different looking than the rest of it. That's the seizure starting just in one part of the brain and kind of just, that person's only having a seizure in the left temporal area. Whereas this person, you can see the difference, it's the whole brain at once. So that's focal versus generalized. Focal seizures can look different, present different, because they're only happening in one part of the brain. It depends what part of the brain. So if they're happening in the kind of the frontal central area, that's where your movement is, your motor strip. So you'll see kind of movement or stiffening, something of like one arm, one side of the face. It's not the whole body, but just part of the body will move. If it's in the temporal lobe, you can get kind of that's where your fear focuses. You can get like weird smells, fear type symptoms. If it's in the back of the brain, that's where your vision center is. So you can actually get strange hallucinations when you have seizures from there. So it's really they can look all different, but it's coming from just one part of the brain. Whereas generalized seizures, there's the way I kind of like to break them up to make it a little bit easier. There are 3 seizure types that are associated with anyone with epilepsy. So people that have totally typical development can have generalized tonic-clonic, myoclonic, and what we call typical absence. But if you start getting into atonic, atypical absence, tonic, spasms, those seizures there, those are really just seen in people with developmental issues, neurogenetic issues, autism, that kind of thing. So I'll go through them one by one, but the top few can be seen in anybody, and the bottom ones are really more kind of reserved for people that have more difficult to treat epilepsies with some underlying neurological issue. So just to kind of go one by one, and I won't spend too much time, but generalized tonic-clonic is what people used to call grand mal. So if you say that, if someone tells you you have grand mal seizures and then someone else says tonic-clonic, it's the same thing. That's just the fancy updated word is tonic-clonic. And it's basically, tonic is stiffening, clonic is shaking. So if you actually watch one of those seizures from start to finish, you'll see a quick stiffening phase. You often miss that because you don't catch the very beginning, but you'll see a quick stiffening and then you'll see the shaking. They can begin as a focal seizure and spread, or they can just start off, with the whole brain at once. What we call a postictal time. Postictal means after seizure. So when you have a seizure, there's always a period of time where you're just not quite yourself. And depending how intense, how long the seizure is, will kind of dictate how the postictal time. So these seizures are usually bigger, they're usually longer, and it can last minutes to hours. It's usually fatigue, it's confusion, there's often sleep. So sometimes if you find someone who's just out of it and sleeping for no good reason, they may have just had a seizure. So that's always one thing to think about. Myoclonic seizures. So myoclonus is just a really quick twitch. Some of you are going to fall asleep during this, and I don't blame you. And when you do, when your head drops, you'll get a quick twitch like that, and that's a myoclonic jerk. And that's normal in all of us. We all get them. We all get them as we're falling asleep. We get them during sleep. You get that dream where you're falling off a cliff and you jump. That's myoclonus. When you're getting it during sleep, that's normal. When you have a big kind of batch of twitching during the day, wide awake, that's not typical, and so that's what a myoclonic seizure looks like. And I'll talk about these a little bit later with the non-epileptic myoclonus. But myoclonus it's an odd thing in that it can be epileptic or non-epileptic. When you have drop seizures, when you have tonic-clonic seizures, those are very clearly seizures always. But myoclonus is a little bit trickier because you can see it from a lot of different issues in the nervous system. You can provoke these seizures from startle sometimes. If you hear a real loud noise and you've got myoclonic seizures, you can just kind of go into one. They're very brief, lasting seconds. We mainly see them in younger children. And like I said, there's benign variants of it. So absence seizures, we used to be called petit mal. Now they're called absence. It's really an abrupt loss of consciousness. Just kind of, you're just doing your thing. You stop, you stare, and then you kind of go back to what you were doing. With typical absence seizures, which is really not what we see in Angelman, people will have a seizure and then just pick up right where they left off. They'd be in mid-sentence, stop for 3-4 seconds, and then just pick up where they left off. They're usually really quick. They're usually like full loss of consciousness, and there's really no postictal type period. For atypical absence, which is what kids with Angelman have, that they tend to be longer. They tend to have some partial awareness, so you're not always totally out of it. You might just be not quite yourself. And they can be, like I said, they can be longer, and they're often seen with other types, with the myoclonic, with atonic. So those are the ones that we really see in Angelman syndrome. That slide I showed earlier, that's what we call, that's the EG of a typical absence seizure. So the spike in the wave, there's 3 of them in a second. And you'll have to take my word for it, but if you look at the green lines and you count in between, that's a second, there's 3 of them. Whereas if you look at an atonic seizure, there's, it's not quite as like, I don't say it's pretty, but you don't have that really, the classic spike and wave. It's more kind of diffuse, and it doesn't have the same shape, but it's also, there's less than 3 in a second. So that's what an atypical absence seizure looks like. So you can tell clinically by how long it is, how aware, unaware someone is, but electrographically we can see too, they look very different electrically. So atonic seizures, these are basically drop seizures. So it's just a quick loss of tone. You're doing whatever you're doing, and you just all your muscles just go loose, and you fall. Sometimes they can be mild and just have a head drop. Sometimes they can be more severe, and the whole body will drop. And these are they're such short seizures, they're a second or less, so it's in terms of what it does to your brain, it's really not much of anything, but when you lose tone like that, you can fall and you can bang your head, and so it's one of the most dangerous seizure types, even though it's just so short. So we would like to try to get those under control if we can. I like this slide. This is an atonic seizure that somebody had during an EEG, and is there a pointer up here? Probably not. It does? Oh, can you see the arrow? Ah, nice. So if you look up here, there's all this like dark black stuff is actually muscle artifact. So when you look at an EEG, if you bite down and you kind of put your fingers here, you can feel the muscles tense. So the electrodes pick that up. So what you see is all this like muscle tensing, and then gone. So this is where the atonic seizure happens. Electrographically, you see this kind of slow wave, and then it's a little flat for maybe not even a second. But the thing that really stands out, which is it's a really good example, is that muscle tensing just goes away for 2 seconds, and then boom, it picks right back up. So that's what we see. We see a quick, less than 1 second drop, maybe a second or two of a little bit of confusion, and then just right back to where they were. So, but it's a good example of how quick you can just lose your muscle tone, and that's why your head drops, the body drops, and we really have to be careful with those. Again, they're so short, but you hit your head, and it's not good. The last two seizure types are really rare in Angelman syndrome, but I just wanted to bring them up. So the tonic seizures and spasms. Tonic seizures is, like if you look at a Tonic-Clonic seizure, it's that first phase where you just stiffen. So kids will stiffen for several seconds. It could be up to a minute. And then with spasms, when they happen when you're an infant, they're called infantile spasms. But outside of infancy, they're known as just epileptic spasms. That's just the seizure type is spasm. So that's almost like a mini tonic seizure. You get this quick stiffening and then it just stops. It's maybe a second at the most. But they're really difficult to treat. They come with the highest level of developmental regression, but they're really rare. There's been some case reports, but I'm not convinced that they were. I don't know if they happen in Angelman syndrome. They might, but if they do, they're really rare. They typically come with areas of cortical dysplasia, and a lot of dysplasia is just an area of the brain that doesn't develop quite right before you're born. There are genetic syndromes like tuberous sclerosis, like 15q duplications, where those are really common, and those kids have a lot of spasms. But in Angelman syndrome, we don't see that. We don't see dysplasias. We don't see abnormal areas of brain like that. So, which is why you don't really get the tonic seizures or the spasms, which is good because those are the two most difficult to treat. So those are the seizure types. You have, your more kind of benign types. You have the ones that are associated more with kind of more severe epilepsies. What you do is you take those seizure types, you add in some specific EEG findings, and then kind of how you're doing cognitively, and you can actually create an epilepsy syndrome. There's a bunch of them, and I won't go into them. The two that can be associated with Angelman syndrome, typically one is Lennox-Gastaut syndrome, and that's always confusing because you say, well, I already have Angelman syndrome, why do I have Lennox-Gastaut syndrome? But it's different. The Angelman syndrome is the genetic diagnosis. It's, what's going on in the DNA that causes it. But the epilepsy syndrome is just how you describe the epilepsy. And really, whether someone calls it Lennox-Gastaut or not, it doesn't really matter. It's, it's more for nerds like us. But it's basically mixed seizure types. So if you have atypical absence and you have head drops, and you have that slow spike and wave that I showed with the atypical absence seizure, and you have some cognitive slowing, that's Lennox-Gastaut syndrome. And it can be mild, it can be severe, so just because it's there doesn't change anything. And so that's why I wanted to bring it up, because sometimes people hear that name and they get worried because it's a new diagnosis, it's something else, but it really isn't. It's just how you describe the epilepsy. And some people might call it that, some people might not, but that's all it means, is just that you have these different things that go together. The other one is called Myoclonic Status and non-progressive encephalopathies, which is not an easy thing to say. It's not common. I say we've seen about 230 people with Angelman syndrome, and we've seen maybe 3 cases of it. It's not common, but it's basically non-convulsive status, which we'll talk about later, but with constant myoclonic jerking. See it in young kids, and like I said, it's not very common. Luckily, it can be tough to treat, but that's you have that classic EEG finding of just the constant spike and wave. You've got the myoclonic twitching, and you have the developmental regression. So those 3 things, make the syndrome. So I think I just talked about all that. But Lennox-Gastaut, as I said, it's the EEG finding, it's the cognitive delay, it's the mixed seizure types. In between, the spike and wave kind of looks like this. It's not that 3 in a second. Like this is kind of 1 second from here to here, and you can barely squeeze 2 in. That's maybe even 1.5. So it's just kind of what we call like a slow spike and wave. And then, like I said, the myoclonic status and non-progressive encephalopathies, rare, begins early in childhood. But even though it's rare, when the first paper came out several years ago, about 40% of the reported cases were people with Angelman syndrome, or small children with Angelman syndrome. So even though it's not very common, when you look at the group of people that have this, Angelman is probably the most common diagnosis that pops up. So moving on to, does that make sense to everyone? You have your seizure types, and then when you mix them with EEG findings and cognitive functioning, you can get a syndrome of seizures. So hopefully that makes sense. Moving on to status. So status epilepticus, that's basically a seizure that doesn't stop. And the definitions vary. There's like a new consensus every year. But typically the main 15 minutes is one that's kind of most commonly thought of, but it's changing. The range is 5 to 30 minutes. The magic of 5 minutes, which is when we say give diastat at 5 minutes, if you have the diastat, it usually says, after 5 minutes of seizure, give it. There's no magic about 5 minutes, that it's not at the 5 minute mark that you're going to have brain damage or something scary. It's just that most seizures stop within 2 to 3 minutes, so if it gets to 5, you don't know if it's going to be a 6-minute seizure or a 40-minute seizure, so that's when you start giving the medicine, because you just want to kind of stop it before it kind of goes and goes and goes. So that's the magic of 5 minutes. It's not that if it goes to 6 that there's going to be serious issues. It's just that when you get to that point, you don't know how much longer it's going to go, so you just start treating it. So because of that, a lot of people are now saying it's 5 minutes, but it's really pretty subjective. But it's basically a seizure that doesn't stop. And if it goes more than 5 minutes, we say, okay, it's time to start treating it because we don't know when it's going to end. But it's really not common in Angelman. It does happen, but it's not something we see all the time. So this is a big one, non-convulsive status. So non-convulsive status is when your EEG is constantly, actually I'll sneak over and come back. I know I used that one for the atypical absence, but this is actually a kiddo of ours that was a non-convulsive status. It's just basically your seizure is just constantly spiking. It's basically a continuous electrographic seizure, but not clinically. So what you typically, the classic story is, you go on vacation, you don't sleep well for a week, you get a little bit cold, you come home, and just things don't get better. The sleep's still off. All of a sudden, a little bit less coordination, and so you see things kind of just slowly going downhill, and that's kind of the classic story for non-convulsive status. There's usually a trigger, and when it can be illness, it can be something like a vacation where you just don't sleep for a while. It can be significant anxiety. But kind of once it tips off, it just often stays until you treat it. The good news is that when, it's the kind of thing that we treat at home. I know it sounds scary, continuous seizure that's, going on for days, but it's really not so much of, it's tough. It's not really status like convulsive status when you're constantly seizing. If that goes on for an hour, 2 hours, that's when you can start to have damage to some of your brain cells. With non-convulsive status, it would take months probably to have damage. Not that you want to wait months, but just knowing that, if you don't recognize that it's a non-convulsive status for several days or a week, it doesn't change things too much. But when you do recognize it, it's important to really get it treated as quick as possible. What's interesting was that in the literature, the ranges are 50 to 90% of people with Angelman syndrome. It didn't seem like that much for our kids. So we looked back, and out of 104 kids that we saw that were, I want to say 8 or I can't remember. I think we picked 8 just because that's when seizures tend to get better. Kind of 8 or younger out of 104. We only had 21 that had been in non-convulsive status. So that's only 20% for our clinic. So I don't know if the studies were just selected. The way the people were selected for the study, they were, hospitalized, or they were in clinics, or if we just get lucky with the rate. But what we're seeing kind of on a day-to-day basis, about 20% of children go into it, and it's really rare in adults. Actually, I don't know if we've seen it in an adult. But so as I said, it's basically just this kind of this EEG change that causes this kind of gradual kind of plateauing and then loss of motor skills, of communication skills. But the good news is it's not permanent, and when treated, kids just go right back to where they were, which is great. The main thing to remember is that regression is not part of Angelman syndrome. Kids don't just naturally go backwards. They don't regress. They don't lose skills. If they are, there's a reason. And it might not be non-convulsive status. It could be bad sleep. It could be behavior related. It could be that you're on the wrong medicine and you need to try something different. But the thing that needs to be kind of ruled out quickly, and if it's there treated, is the non-convulsive status. But if you see regression, it doesn't have to be non-convulsive. It could be something else. But it's not the syndrome. It's not part of the natural history. You don't just regress, which is great. And then, like I said, for frequent myoclonic, so with this whole picture, plus lots of twitching, that's myoclonic status. But the treatment's the same. So that's that. So looking at Angelman syndrome specifically, so epilepsy and Angelman syndrome is a classic generalized epilepsy, which I know sounds weird, but about 1/3 of kids will have focal spikes on their EEG, and about 1/3 of kids will have focal seizures, just kind of one arm shaking or the eyes to the side. But those are focal findings and focal seizures in the context of a general. I know it sounds weird. It's epilepsy. It doesn't make sense. It's in the context of a more generalized epilepsy. And when you treat a generalized epilepsy, there's certain medicines we'll talk about at the end that will make it worse, so you have to be careful. But the main seizure types are tonic-clonic, the atypical absence I talked about, the atonic, the myoclonic, again, focal seizures in maybe 1/3 of people, and then rarely, if ever, tonic and spasms. Those are two types we really don't see, which is great. And it makes sense because there's no kind of what we call dysplastic areas where the brain just isn't developed quite right. So the first big study that we did, this was my introduction to Angelman syndrome back in 2006. We did a seizure survey through the ASF online, and we got 461 responses. What we found was that 391 had seizures, about 86%. With these kind of surveys, you're kind of prone to getting more people to respond who had seizures than don't have seizures, but I think that's pretty accurate. It seems like it's in the 80 to 85% range. 60% had multiple seizure types, and like I said, 30% had focal findings. These were the most common, and the one thing I'd say we probably didn't capture properly is the myoclonic seizures. Those are more common. Those are probably more in the neighborhood of atonic and absence. On a questionnaire, it's really hard for parents to differentiate between like a kind of a tonic-clonic versus quick twitching. In the clinic we can talk about it and demonstrate it and really get to the bottom of it, but in a questionnaire I think that was hard to really capture properly. But the rest of the thing is pretty accurate: tonic-clonic, absence, atonic, focal, and the tonic and the spasms were probably not really tonic and spasms. They're probably different types. We recently saw someone who was diagnosed with spasms who we eventually got the original EEG, and they definitely weren't spasms. So that can be misdiagnosed. Among genetic subtypes, and again, these are probably all a little bit higher just because of the way a seizure, like a survey, is weighted. And this is kind of what we see in clinic. It's 90 deletion was about 90%, UPD and UBE3A about the same, about 75%, and imprinting center about 50%. I think that kind of that breakdown of percentages is right. I think the overall numbers for each are probably a little bit lower. Again, it's a survey, so things can be overestimated. So the numbers aren't probably that high, but that deletion being higher than UPD and UBE3A being higher than imprinting, I think is exactly right. And that's what other studies have shown as well. Relative to age, seizures typically begin around 2 to 3 years if they're going to. It can be a little bit later, it can be a little bit earlier, but that's kind of the the classic story is, had his 3rd birthday, had the seizure the next day. That's really a very typical time. They seem to be most frequent in that kind of 3 to 8 range, that early childhood into their early school years. They tend to get better around puberty for most people, and then they can return in persistent adulthood. In the fabulous study that Dr. Larson did recently, it showed that about 1/3 had seizures recur in adulthood. But what's nice though is that even though there's a decent, it's a much smaller amount, still 1/3 of people, that 1/3 of adults where they came back, they were not always, but typically much milder and much easier to treat. And it's not 100%. It's not for everybody. Sometimes there's outside factors that aren't really related to the Angelman syndrome even, but in general, seizures tend to get better around puberty and then often stay away, but sometimes kind of come back. But when they do, they're usually not as bad. Not always, but usually. And looking at the EEG and Angelman syndrome, so I won't bore you with the nerdy details, but just to know that there's when you get an EEG result back and it says abnormal, it doesn't mean that there's an increased risk of seizures. So when we look at EEGs with Angelman syndrome, we look for kind of what I've been showing, that spike and wave, just these kind of waves in between the seizures that tell us that the brain's a little bit more irritated and might want to have a seizure. So we look for those. But the other things that we find that, and often this is what makes an EEG come back abnormal, are these kind of strange notch patterns. So if anyone was at the scientific meeting, or I think they probably mentioned it when Ben and Stormy did their review, there's a lot of what we call delta activity in EEGs and for kids with Angelman syndrome. So they kind of named the speeds of the EEG in these kind of Greek letters. So it's basically bumps per second. You look at the second and how many bumps you have. Delta means you have less than 3. So that's kind of at the slow end. So what we see is, kind of just typical looking EEG. It's just I kind of shrink it down to fit the bumps on, but kind of regular EEG, and then all this kind of run of notching. It looks, some of them look like they have bites taken out of them, which is kind of weird. It's a slow rhythm with these kind of little sharpish pieces in it, but this is really common. About 96% of people with Angelman syndrome have this to some degree, and we don't think it's a good thing to have that, but it doesn't tell us that seizures are more likely to happen. When we treat seizures adequately, when kids are sleeping well, when things are going really well and life is good, we see less of this. So we know that the less the better, but the exact kind of reason it's there is unknown. This is the classic occipital notch delta, like you'll see it all the time on reports. It's in the back of the brain, so each of those kind of rows of 4 goes front to back. So in the back you see this really tall, slow activity with some sharpness. Often it'll say runs of delta with sharp activity, but we've had people come in that said, frequent occipital seizures, and parents are really confused because the kids look great, they're doing great, they don't see any seizures, but then the EEG comes back as frequent seizures. That they're not seizures. There's a notch delta of Angelman syndrome, but sometimes if it looks spike and wave enough, sometimes it'll be read as seizures. So that's important to know, that if you get an EEG report back and it says, frequent seizures, and you don't think you're having any seizures, then there's a good chance they're not seizures. So just something to kind of keep in mind. So non-epileptic myoclonic. So this is a kind of a tricky one. Sorry, what's that? Yeah, not handling the heat well. No. So going back to Dr. Larson's first paper, looking back, it was a great study that was. She actually talked to 110 parents of adults with Angelman syndrome, often for 2 hours at a time, collecting all this information. And what we were finding was that there was this kind of odd pattern that we didn't expect, where they'd say, had seizures when he was little, got better, and then this different type showed up, and they go for hours, and it just didn't make a lot of sense the way things were. And then we started seeing it more in clinic, and so. Again, talking about the myoclonic seizures, common in Angelman syndrome, somewhere between 15 to 40% of people with Angelman syndrome have it. Typically early onset. It's often the first seizure type. It's usually real early on. Brief in duration, usually seconds, usually during wakefulness. And then if you catch it on an EEG, you'll see a burst of spike and wave. Like you'll see the twitch and you'll see a big burst on the EEG. So that's how you know it's a myoclonic seizure, not just non-epileptic myoclonus. We looked back at our at that point, we'd seen 185 people in clinic, and about 15% had myoclonic seizures. The age of onset was 1 to 8 years, but about 80% had the onset before the age of 5. So again, kind of at the low end, but in that range of what the literature says of how common they are. And the age of onset, probably kind of the youngest age of onset we see. But what we see in non-epileptic myoclonus, and we talked about that a little bit this morning in the GI talk, was that the age of onset is typically puberty or later. The events can last seconds to hours and happen multiple times per day. What really separates these is that there's no alteration of consciousness. So we have a teenager or an adult that just starts twitching, and if you try to hold their hand, you'll just feel them keeping twitching under your hand. And often they're just in the hands, and they're mild. Sometimes it's the whole body and the face, and it's really kind of scary to watch. But when these happen, they are awake, alert, they try to eat, they try to drink, they just can't do it as well because they're shaking so much. And when it stops, there's no postictal period. So if you were to seize for 3 hours, you would sleep for 12 hours probably. But when this finishes, they just go back to what they were doing. They're tired because it's almost like a workout. It's like going to the gym because you're twitching so much. But it's but it's non-epileptic. Initially, we really had no idea what it was, so we started getting some EEGs on some of our teens and adults, and overall we've had 12 individuals with prolonged EEG that captured events, 5 with inpatient video, 3 with us at Mass General, 2 in outside centers, and then 7 that had ambulatory, so that's when they hook you up and send you home, 2 with us, 5 from other centers, and in all 12 there was no epileptic activity on the EEG during these events. So really kind of supporting what we could see clinically, that they're not seizures. But just because they're not seizures doesn't mean that they're fun. The good part is that since they're not seizures, there's no real danger to the brain. It's not going to affect development. It's not going to cause a regression. It's not harming the brain at all. But on the other hand, it just must be awful. You're just twitching for hours, so it causes anxiety. It's got to be. It's as opposed to a medical emergency kind of issue. It's a quality of life issue, but it's a big quality of life issue. So we treat it aggressively like we do seizures because it's such a big quality of life issue. But knowing that it's not, go to the ER every time it happens because we know it's not dangerous. It's just a really, just a terrible quality of life issue. By age range, so 0 to 10, nobody, 11 to 20, a little more, 21 to 30, a little more, 31 to 40, about the same, and then 41. So, well, only 2, but our 2 40-year-olds both have it. And I think it's also important to note that both of our folks older than me are both still walking independently and doing great. So it doesn't seem like it's a degenerative kind of thing. In some neurological, neurogenetic disorders, as the brain deteriorates, you get myoclonus, and then things just get worse and worse, and things go downhill. But we've seen people now in their 40s that have had it for probably decades and are still walking around and doing their thing and just happy and healthy and looking good. So it's a small N. It's just a couple, and a few others in their late 30s, but it's a good sign that they're doing so well with this myoclonus and that it's not degenerative. It's just probably part of the movement disorder of Angelman syndrome. When kids are younger, it's more off balance and maybe tremor, and as they get older, it's more kind of twitching. So we think that's what it is, which is good. And this is the age of onset, so one of them had a little bit earlier age of onset, like 9, but most are in the teen years, and then some in the early 20s. And then I won't go into too much, but the duration, basically what the kind of the take-home message is that the teens typically have shorter episodes. Once they kind of hit 20 and above, that's when they start to have the hour-long, 2-hour-long, 4-hour-long. We had one woman that had it for 24 hours. She had to go to the ER just because we were afraid she wasn't going to eat or drink enough. So seizure treatment. So that's basically seizures in a nutshell. We did it in 45 minutes, but it's a lot to digest. So treatments, again, it's a lot to digest, but I'll try to go kind of hit the highlights and go through it as quick as we can. And we've mentioned it in other talks, the anxiety, the GI. The best thing you can do to treat seizures is treat everything else. So if you're having a lot of seizures, it's really just natural, and it's kind of intuitive to say, I'm going to deal with the constipation later. You can deal with the sleep later. We have to focus on the seizures, but that's actually going to cause more problems. You really have to treat everything at once because, like I said this morning, constipation will worsen your sleep. Bad sleep will worsen seizures. You seize more, you get more anxious. That anxiety worsens the sleep more. It's this vicious cycle, and if you really kind of have to kind of try to improve everything, because if one of those pieces is off, it's going to throw the rest of them off. So sometimes our best seizure medicines are Miralax or Trazodone. It just really, if someone's not sleeping, if someone's not pooping, it's really going to be an issue. So not that you do that and ignore the seizures, you treat them both, but when you start someone on seizure medicines, you always think, okay, why did the seizures pop up now? And is there something else that we can treat to really try to make this easier? So the treatment options, so there's kind of 3 big categories for treatment options. There's medicines, there's dietary therapy, and then there's surgical options. And then at the end, I'll talk a little bit about non-convulsive status / epileptic encephalopathies as well, and the non-epileptic myoclonus. When we did the seizure survey in 2006 to 2008, these were the most commonly used medicines. So by far, Depakote, next Klonopin, and then after that, shockingly, phenobarbital. But beyond that, Topamax, Tegretol, lamotrigine. And I think this is also part of the reason why those numbers seem a little bit higher than they should be, because phenobarbital and Tegretol will worsen seizures in Angelman syndrome. So we had a big chunk of kids that were on medicines that we know will make their seizures worse. So that's part of the reason I think those numbers are a little bit higher. But looking at that, and then looking at kind of how we break down medicines, when you have a generalized epilepsy, we use what we call broad spectrum seizure medicine. So a broad spectrum medicine is one that doesn't just treat tonic-clonic and focal seizures, but it will also treat head drops and absence and atonic, absence and myoclonic. These are the kind of the classic pre-2011 broad spectrum medicines. So ethosuximide or Zerontin, the benzodiazepines, Klonopin is the one that's really can be used more on a daily basis because it's got longer, it just kind of acts longer versus Valium, Ativan, those kind of meds. 20, 30 years ago, Transine was another big one, so we see some adults on Transine, but it's not really used that much anymore. And then after that, Depakote was the first, after those, the first kind of like true classic broad spectrum medicine. So, but after that came out in the 70s. After that, Felbitol, Lamictal, Zonegran, Topamax, Keppra, that was all 95 to 2000. There was a big kind of push in the late 90s. So anyone that had seizures before 1995, the two best medicines were Depakote and Klonopin. That's what you had, and those were by far the best choices. We know now that there's others that are better, but at the time those were the best. But as we'll see, in terms of the non-broad, so there's not a fancy word, but ones that aren't broad spectrum medicines, phenobarbital and phenytoin or Dilantin, those medicines, and there's some controversy. If you're in status epilepticus, you just need to stop it. And so if you need to use Dilantin or phenobarbital, then you use it because you want to stop them. But it's not something you want to keep people on long term. But to give it IV in the ER, it should stop status epilepticus and Angelman syndrome. But given on a daily basis, especially Dilantin, it'll worsen head drops, it'll worsen absence seizures. Not in everybody, but in most people. And then the other one, carbamazepine, which is Tegretol, and oxcarbazepine, which is Trileptal. Great medicines for focal seizures, but they will worsen staring spells and head drops. They almost universally will. So we've seen several kids who have come in on Trileptal and just seizing a bunch, and we didn't even switch their meds. We just stopped it, and the seizure stopped. So it's a real thing. And there's two other medicines that aren't broad spectrum that we do use. So gabapentin or pregabalin, as expected, they don't really help seizures in Angelman syndrome, but they don't really hurt them either, and they're good sleep medicines. So we use a lot of Neurontin actually to get the gabapentin for sleep, and it works for a lot of kids, and for the kids it doesn't work for, it doesn't worsen their seizures either. It just doesn't work, so we stop it. But they're not broad spectrum, but they don't really worsen seizures like Trileptal and Tegretol would. So there's that kind of that boom of meds in the late 90s, and then there was another one in the last 5 years. Clobazam, which we had been using for years from Canada, kind of getting it like smuggled over the border. That was legal, but we had to send the prescription to Vancouver, and then they would mail it in, and it was crazy. It was finally approved in the U.S., and now we don't have to. So the brand name in the U.S. is Onfi. And then around that time, rufinamide or Banzel, lacosamide or Vimpat, Potiga, Fycompa, Aptium, and now Briviact. Potiga you don't have to worry about anymore. It's off the market. It sounded exciting at the time. It was a potassium channel blocker. So the way seizure medicines work is that you have your brain cell, and there's these little like sodium, potassium, calcium, these ions. They go in and out of the brain cell, and that's how you get the electrical message sent to the next one. And the way one brain cell talks to the next one is it kind of shoots out these transmitters. GABA, which you'll hear a ton today, you probably have already. GABA is the main chemical that quiets things down, and glutamate is the one that kind of speeds things up. So the way you can treat seizures is to try to stop those ions from moving in and out of the cell as fast as they do. Typically sodium and calcium. Potiga was the first, did I say calcium and sodium? Potiga was the first potassium channel blocker, and people were excited, but then it started turning people's skin blue, and so it came off the market. So we don't have to worry about it. The medicines that work really well for Angelman syndrome, we talked about them in the anxiety talks, and of course, I'll talk about Onfi now, but the benzos, I don't know if Logan's here, but she mentioned that they seem kind of magical. They do, and there's definitely something if for those of you that saw her talk, she's dead on. There's something in the GABA transmission. There's GABA genes next to the UBE3A gene, GABA receptor genes that are deleted in kids with deletions, turned off in kids with UPD. There's got to be something about deleting those genes that just totally messes with the transmission of GABA. It's not super well understood, but the fact that the benzos work as well, they work so much better for kids with Angelman than any other kids that we see. So there's definitely something to that. The opposite of that, similar but opposite, is instead of increasing GABA, Ficampa perampanel, which is fairly new, is a medicine that quiets the glutamate. So instead of increasing the stuff that slows things down, you're decreasing the stuff that speeds things up. So we haven't used it a lot yet, but it's something that that we've started using, and so far it's been helpful. But that's definitely one that we're excited about. But overall, as you'll see, Onfi is probably our favorite medicine. Anything in the benzo family is great. The other ones, Banzel, Vimpat, we haven't used them a ton, but I think when we have, they've been okay, and I think they're definitely worth using. But Boutique's, you don't have to worry about it, it's off the market. Aptium, which is eslicarbazepine, so it's the third generation of Tegretol. Tegretol is carbamazepine, Trileptal is oxcarbazepine, this is eslicarbazepine. So there's some talk that when it came out it was more of a broad spectrum, but until that's really proven, I'm really nervous to use it in kids with Angelman, because if it works like Trileptal and Tegretol, it's going to make things worse. And then the one that we're really excited about is brivaracetam or Briviact. If the acetam sounds familiar, it's Keppra's levetiracetam. So Briviact is so it's 10 years ago we started hearing about brivaracetam, that it was the next big thing that was coming out, so it took forever for them to get it to go through, but it's very similar to Keppra, and it causes less crankiness. So we don't know yet if it's as effective as, because Keppra is super effective when it doesn't make you cranky, but we've been using it some in the folks with myoclonus, and so far so good, so I'm hopeful for that one. But looking back at the folks we see in our clinic, kind of thinking back about the initial seizure survey we did where so many people were on Depakote. What we saw, and I didn't make a slide for it, but we saw that newer medicines like Keppra, like Lamictal, Onfi wasn't around in the US, so we didn't really have any data on it, but at least those two, to a lesser degree Topamax, that they were pretty much as effective as Depakote, maybe a little bit more, but with way fewer side effects in the Angelman population. So we decided to look back at the people that we saw in clinic, and this got published not even a year ago. But what we saw, and these seizure rates are probably a little bit elevated overall, just because they're often, because you're using multiple medications together. But basically, when these medicines were introduced, looking at those that are 50, 90% or 90% better, Depakote has good efficacy. It works. I mean, it does. It's a good broad spectrum medicine. It treats the seizure types that you see in Angelman. But Keppra and Lamictal and Clobazam seem to work as well, or maybe a little bit better. And then just as we'll talk about diet therapy a little bit later, we kind of threw that in there, and that works, as well as these medicines. Honestly, it probably works better. It's often when it doesn't, it's the tolerability, that kind of, and by both the child and the parents. But looking at the next slide, so looking at adverse effects, Keppra, Keppra gets a bad name. The psychiatrists hate it because of the irritability, the crankiness. But really, in the studies that have come out since Kepra's been released, they all say about 20% get the irritability, the anger, the rage. And what we found in our folks with Angelman is 20%. So it's pretty much exactly the same. A lot of people think, well, if you already have behavior issues, it's going to make it worse. It doesn't. It doesn't matter if you're cranky to start with or not cranky to start with, you get that worsening of behavior in about 1 out of 5. And if you see it, and sometimes going to brand names, sometimes adding vitamin B6 helps, but if it doesn't, then it's not worth the crankiness. We stop it and move on. But that was the deal with Keppra. Lamictal, very minimal side effects. Clobazam, unfortunately, even though it's probably our best seizure medicine, about a third of people will get some sleepiness. Rarely the opposite, you get a little bit agitated from it. Kind of, sometimes you give someone Benadryl and they bounce off the walls. It's kind of the same concept. But Depakote, 66%. And what's really striking about the Depakote, and I know I've said it at other conferences, but we see a really remarkable decline in motor skills with a lot of the kids we put on Depakote. It's not, as you see, it's 2/3. So some kids really don't, kids/adults don't have big issues, but we've seen it to the point where we've now had at least 3 teenagers that never walked until they came off Depakote, and at 12, 13, 14 took their first steps, and it wasn't a coincidence. We've seen it both ways. We've seen Depakote start and regress, and we've seen kids that have been on it since they were 2, just like have a life-changing moment by coming off of it. So it's the kind of thing where if someone's on it and there's no sign of anything wrong, then you don't have to rock the boat. You can just stay on it if you're doing well. But we typically don't start it because there's such a high risk of side effects. And if we do see someone who is doing well cognitively and doing well, behaviorally, and seizures are okay, and they're not walking and they're 10, they're 12, then it's probably the Depakote. And we've really seen a lot of improvement in some people coming off that medicine in their teen years. So kind of a basic summary of the medicines. And this is just from our clinic data, so it might be that other medicines work just as well, but the 3 that really stood out were Keppra, Onfi, and Lamictal. The nice thing about Keppra and Onfi is that they both help treat myoclonus, so whether it's epileptic or non-epileptic, they're great myoclonic meds. Lamictal is not a great myoclonic medicine, but it's great for everything else. The other ones that we have used with effectiveness and with varying rates of side effects: Topamax, Zonegran, Klonopin, which is great, but the main thing with Klonopin was it causes some sedation. Doesn't mean we don't use it; we use it a lot, but it does cause some sedation. The other thing that Klonopin and the other benzos can do is cause decreased tone. So if you have low tone to begin with, it might make mobility a little bit harder, especially in the little ones, and it decreases your tone in the GI tract, so it can sometimes worsen swallowing problems, worsen reflux, worsen constipation, so much more than clobazam will. So we tried to use it sparingly, but we do use it. I mean, it's a great medicine, but it does come with side effects. So looking back to the seizure survey, when you see all these people that were on Depakote and Klonopin, they weren't put on it because people were choosing the wrong medicines. They were by far the best 2 medicines available until the late 90s, but what we're seeing now is that the newer medicines tend to do the same thing, but with fewer side effects. The next slide. So again, Depakote, broad spectrum, it does work. It's going to treat the seizures. It actually is good for myoclonus, like Keppra and Onfi are, but we see so many side effects. And we don't know why, but my person, and this is not proven, it's just my theory, is that the one thing we know about Depakote is that we never ever use it in kids with mitochondrial disorders or other metabolic issues. It's tough on the mitochondria, it's tough on the liver, it depletes your carnitine, so if you have a metabolic type issue, it's just universally not used. And my guess is that there's a very slight metabolic issue in Angelman syndrome, but even a slight metabolic issue, Depakote can cause issues. And my guess is that's what it is. My hope is to look at the mitochondria someday. We have a very smart mitochondrial person at Mass General who I'm trying to talk into looking at it. But there's little clues. There's how some kids, they get sick and they don't bounce back as well, how the illness really can put kids into non-convulsive status. Those are really common in kids with mitochondrial issues. There was a study that came out a little while ago with mice about looking at coenzyme Q, and even though I'm not sure that's going to be something that helps humans, the fact that it was there in mice, that's a very typical mitochondrial kind of thing. So curious to know why, but regardless of the reason, but that's just what we see in clinical practice. Depakote can really affect your motor skills. And then the other, so the newer broad spectrums, Onfi, we love Onfi, but Banzel, Vimpat, Fycompa, Briviact, I think are all going to be good options. We just haven't used them as much because they're newer. But, and then the 2 non-broad spectrums that don't really help but don't seem to worsen things, Neurontin and Lyrica. That's important because Neurontin can be a really effective sleep medicine for some kids. And as far as the other non-broad spectrums, Tegretol, Trileptal definitely worsen seizures. Aptium, until it's proven otherwise, we have to assume it's going to worsen seizures because it's kind of genetically similar to Trileptal and Tegretol. It's in that same family. And then the ones that we know worsen seizures on a day-to-day basis, but they come IV and they will stop convulsive status, Epilepticus, Dilantin, and phenobarb. So if you're in an ER, there's status, and ideally, Keppra is a great first choice. It comes IV, but if that's not readily available and there's phenobarb and there's Dilantin, that you use them because they will stop the seizure, and then you can always just kind of sneak off them afterwards. So moving on to medicines, there was a fabulous talk this morning, so I don't want to get into too much detail, but ketogenic diet has been used since the 20s. Evidence dates back much earlier, as Heidi mentioned this morning. Well, the exact mechanism is unknown. It's, basically what they found was when you starve people, they stop seizing, and the American Academy of Pediatrics does not allow for starvation. So what they did was they made a diet that mimics it. So when you starve, you use your own body fat, and when the brain uses that fat, it's more stable. And we don't know if it's probably a combination of things, but when that happens, the brain's using fats instead of sugars, but you have low stable blood sugar levels, low stable insulin levels, you have ketones floating around in your blood. So it's probably a combination of many things, but the bottom line is when your brain uses the fat, it's a better option. It's not easy. It's high fat, 90%, allows for less than 10 grams of carbohydrates per day. Ratio of fat and proteins to carbs is 4-1, but can be a little bit less. We have to start with a hospital stay, monitor blood closely for a couple of days. We usually start medicine we do start medicine to counteract the acidosis, because when you're burning fats, you're making fatty acids and your blood pH goes down, you get more acidic. So we start medicine for that. If you're on Topamax or Zonegran, those also do that, so we have to be careful. We can do diet with those medicines, but we just watch very carefully. And then we have to supplement with various things like calcium, vitamin D, carnitine. The low glycemic index treatment is based on the glycemic index of food, so how high it raises the blood sugar. I feel like I should have Heidi come up and do this, and I think she's judging me. No, but it was actually a diet started at Mass General by Heidi and Elizabeth Teal, who I work with back at MGH, and it allows for 40 to 60 grams of carbohydrates per day. As opposed to the ketogenic diet, it's 10% carbs, 20 to 30% protein, and 60 to 70% fat. There's no need for admission. There's we still monitor, at the 1 month mark and then every 3 months, but it's not that daily labs that we have to worry about with ketogenic. The meals are based on percentages and caloric needs, so that you're not weighing everything. It's just a much easier diet to do, and it's less restrictive, and the efficacy is almost as good. So this is what we typically start with. The exception is if someone has a G-tube, because if you have a G-tube, there's ketogenic formulas that are pre-made that you can you switch whatever you're on to the ketogenic formula, and there's really no low glycemic formula. So if there's a G-tube, we do keto. If not, the low glycemic is much easier. And then if you need to convert to keto, you're more than halfway there, so it's not as hard to do. As Heidi mentioned this morning in the paper that they put out in 2005, about a third not effective or tolerated well, about a third 50-90% reduction in seizures, and about a third 90% or more reduction in seizures, seizure-free. When you look at the efficacy of medicines, they are usually about 40% effective, and that's 50% or more reduction. So the low glycemic is about 66%, effective, so it's actually much higher than most medicines, or actually all medicines. We did a trial, so this is kind of exciting. It was the first ever prospective trial, so not looking back, but just starting at point A, kind of logging seizures, starting the diet, kind of watching over time. It wasn't a giant trial, it was 6 kids, but it was the first ever prospective trial for the diet, and it happened to be in kids with Angelman syndrome. It was a grant we got from the foundation. And at the 4-month mark, in that last month, 4 of the children had a 90% or more reduction in seizures. 1 was 50-90%, and 1 had less than 50%. But then after a year, 5 kids were still on the diet, and they were all more than 90% seizure-free. And what's great is that we started this in 2008. They're actually all 5 are still on the diet. We've been following these kids for some of them for 9 years now, which is awesome. Since then, I have the exact numbers. So we got a paper that just came out in Epilepsy and Behavior earlier this year. So as of this point, we've put more than 23 kids on the diet. There's some that we've started that we just haven't seen back yet, so we don't have their information. But out of the kids that we had information for, I won't go into all the details, but it worked. Those with daily seizures all improved, and 1 became seizure-free except for during times of illness. Those with kind of weekly seizures all improved, with 1 seizure-free except in times of illness. 2 had monthly seizures, both became seizure-free. 1 totally seizure-free, 1 except for in times of illness. A couple only had seizures when they were sick, and 3 only had seizures when they were sick. 2 kind of had similar outcomes where they still only have seizures when they're sick, but it allowed them to kind of cut back on their other medicines, and then 1 has been totally seizure-free. 1 kid that we started only had non-convulsive status, and still only has non-convulsive status at times. And there was one child that was well controlled that stayed well controlled, but was able to cut back other medicines. So not only does it help with seizure prevention, but it can, even if your seizures are well controlled, it can help you get off medicines, because some kids just have a lot of side effects. Even if they're our safest, easiest medicines, some kids are really sensitive to any medicine. So the big themes, number one is that low glycemic is very effective for Angelman. It was only 6 to start, now it's somewhere in the 20s, so it's not a huge number, but we just see that the numbers for efficacy for dropping seizures are higher than the general population for epilepsy. And the numbers for epilepsy in general are very good. That kind of 66% with 50% more 50% or more decrease is better than any medicine. Most medicines are about 40%. So it's already good to start, but then in Angelman we've seen even a better efficacy. And what we've also seen is, I didn't write it in the slide, but we've seen some kids do really well on more than 60 grams per day. So we try to start kids on the kind of unless there's circumstances why we don't put them on that 40 to 60 gram per day limit. And if things are going really well, kind of trends up a little bit. And if seizures stay good, we kind of, and we've been able to keep kids on higher amounts, but still with good. So it's just another kind of clue that this really works well in people with Angelman syndrome. Part of it is we've got an amazing group of parents, and that's probably the biggest reason why the diet works. But even beyond that, I think there's something genetic where this just seems to work better. So surgical options. So there's really 2 types of surgical options. One is what we call resective therapy. We do EEGs, we kind of see where seizures are coming from. If needed, we put electrodes inside the skull and look, and then we cut out the part that's seizing. That is not an option in Angelman syndrome. Angelman syndrome is a genetic. It's a generalized epilepsy. And so even if you're seeing some focal seizures, you don't cut that part out, because you could be seeing them all from here, but in a year you might be seeing them all from here. When you have a generalized epilepsy, you might have one part of the brain that's a little more cranky, but that part can change. And so if you cut that part out, you may be better for a month, but then it may start over here. So don't cut anything out of the brain. It's a great option for a lot of people, but not for our kids. What is an option, and we don't use it much, luckily, because I think we have such good luck with the meds and the diet. The vagal nerve stimulator, so that's a device that you implant. It's about this big, under the skin, like in the chest wall, and a little kind of electrode wraps around the vagus nerve. The vagus nerve is a big, thick nerve that comes down from the brain and goes to your lungs and your heart and your stomach, and kind of does all that parasympathetic stuff, the stuff that we don't consciously control. The right one mainly goes down, the left one mainly goes up, so it wraps around the left one, and it sends a pulse to the brain. And as reassuring as it is, we don't know why it works, but it does. It's not something that is going to stop your seizures, but for people that are having a ton and nothing's working, it will, in more than 50% of people, it'll decrease seizures by more than 50%. So it's more like a palliative measure, but it can be really effective for some kids where nothing's working. Luckily, we haven't. I don't think we've ever put one into somebody with Angelman syndrome, which is great. Typically, we get the meds to work or the diet to work, and with some combination, we can usually avoid the surgical options. But that is an option, and it does help. And if others don't, we have a couple of kids that we're thinking about that are just really tougher than the others, but that's definitely an option, and I think it would work just as well as it does for other kids. So those are the 3. So there's meds, there's diet, there's surgery. Looking at non-epileptic myoclonus. So again, it's not epilepsy. The question came up this morning that someone was on dietary therapy for what sounded like non-epileptic myoclonus that wasn't helping, and that's usually the case. Sometimes you do see improvements, but it's because either somebody wasn't getting enough calories, or they were just eating really unhealthy, and then they go on to dietary therapy, and that improves, and then you see an improvement in the myoclonus. But it doesn't work the same way the low glycemic and ketogenic do by kind of stabilizing the brain from epilepsy, because it's not an epileptic process. So what we're left with is, as far as specific treatments, are the medicines that will treat myoclonic seizures. But I didn't put this on a slide, but the best treatment for non-epileptic myoclonus, so this twitching that the teens and the adults get by far, most of the things I've said today, easier said than done, the best treatment is to stop the triggers, because they're almost always triggered. And the biggest trigger by far is anxiety. The other ones are illness, which you can't really control. But if people do get sick, and the best thing you can do is keep people really well hydrated, try to limit fever, just kind of treat the symptoms of the infection. Obviously, if it's bacterial, get that treated as quick as you can. But for most of our folks that have bad non-epileptic myoclonus, we can, and if it's anxiety, it's also not that easy to treat. But we can usually target the big trigger. And if you can stop anxiety, if you can help constipation, if you can get sleep better. Lack of sleep is a huge trigger. So again, it's like that's not easy to do any of those three things. But if you can, the myoclonus may become so mild that you don't even need to treat it. And because it's not a medical emergency, it's not damaging to the brain, it's not doing anything bad other than really affecting quality of life. The treatment is basically just that. If it's affecting your quality of life, we treat it. If it's not, we don't. A lot of people just have a little bit, and it's just in the hands. And if the family members say, you know what, we see it, but it doesn't affect eating or drinking or going anywhere, it doesn't bother him, then we don't treat it. So it's okay to twitch a little bit if it's not bothering you. It's when it gets to the point where it's causing anxiety, when it's making feeding difficult, when it's when it's not letting you go out and do things, that's when it really need to treat it aggressively. But the medicines we use, so there's not a ton of medicines that are great for myoclonus. The best, so Depakote's good, of course, but we don't like that one in these folks. We try to treat with some combination of benzos. So if they're already on Onfi for seizures, we start with that one. But otherwise, Klonopin is a good choice. We have some people on Valium or Ativan. Those are short acting, and so it's harder. But if that's all that works, then we just do it, and we put people on like a little bit of Ativan like every few hours, and sometimes it helps. But we try to mix a benzo with something in the acetam family. So Keppra is the classic one, and that works for a lot of people really well. If it doesn't work, if it's not well tolerated, now we have Briviact or Brivaracetam. So we've had a few people that didn't respond to Keppra, didn't really do much with the benzos, that really did great with the Briviact. So that's an upcoming option. But as of now, that's kind of what we have. There's anecdotal evidence that comes up at every lecture, so I might as well mention it now. There's anecdotal evidence about CBD oil working for it. And it may, we just don't know. So I can't say that it works, I can't say that it doesn't work. We've had several families try it and say that it was magical and that it stopped them, and I believe them. And we've had several families try it and say it did nothing. So it's probably going to be one of these things that helps some but not others. But all we have now is just kind of family reports. There's no true evidence, but it's something that is, I think, promising. It's a potential, but we just don't know enough yet. As far as non-convulsive status, and I'm almost done. So when people have non-convulsive status, or if the seizure is just so frequent that the EEG is just filled with spikes, even if it's not non-convulsive status, it's just spike, spike, spike. We'll call that like an epileptic encephalopathy, and what that just means is that there's so many spikes on the EEG that it's affecting development and cognition, and you see development kind of flatten out or potentially go backwards. So when that's the case, typically adding Keppra, adding Lamictal, doing something, we don't really see a big change, especially for non-convulsive status. So the best thing that we can, the standard treatment for kind of epileptic encephalopathies in general now is Valium. When there's certain syndromes we see often in kids with autism called CSWS, continuous spike wave of sleep, or Landau-Kleffner. The classic treatment's a big dose of Valium at night, like a dose that would like knock us out for 3 days. We give it to kids. We give them obscene doses. They don't sleep because if your brain needs it, it needs it, and you're not going to have that effect where you pass out. So, but we don't do that for kids with Angelman. But what we do is we give more or less start with their diastat dose, break it up into 2 or 3 times a day, give that for a couple of days, give a little bit less for a couple of days, a little bit less for a couple of days, and if need be, we can stretch that out or repeat it, and that really works for most kids with non-convulsive status. If that doesn't work, and we've had a couple of kids that hasn't worked, the one thing that, the other medicine that can really work is prednisone. I know we talked about it a little bit this morning with the immune stuff, but prednisone is, and really it's only it's an anti-inflammatory medicine, so we don't quite get how that works, but for whatever reason, with the anti-inflammation effect, it can be a really powerful medicine to kind of quiet down seizures and just kind of knock out the spikes from an EEG. So we had, like, for one example, we had probably our toughest kid that we see. He came in non-convulsive status. We treated him with Valium, sent him home, and he did great. And then he came back in non-convulsive status, but unfortunately he'd been in it for a couple of weeks. We tried the Valium, it didn't work, so he ended up in the ICU and the whole bit. And he came out of it, he did fine. But when he came back in non-convulsive status, we didn't want him back in the ICU, so we got him in early. We put him on a bunch of actually IV steroids for a few days, and then big doses, tapering down. We got him out of it before he needed to go back to the ICU. So he's been the only kid we've had to do that with, do the whole ICU thing. But between the Valium and the Prednisone, we've been able to really keep most kids away from that. So just a bit overall treatment summary. It's I think my last slide. Assess for seizure triggers and or comorbidities and treat them as needed. So when you see someone and you decide that they're having seizures, they need to be treated for them, you treat them, but you also say, okay, while we're doing this, we're going to work on constipation, we're going to work on sleep, we're going to work on anxiety. And if we can do 2 for 1, so if I mentioned like clobazam, for example, if you have bad sleep and seizures, that might help both. So we may just start that one medicine. Same thing with anxiety and seizures that can help both. So there's certain medicines that kind of can have a 2 for 1 effect, which is great. But when we treat the seizures, we treat the other stuff as well, because you're just not going to make headway if you don't. First line, really, we offer families diet or medicine first line. It works so well, and if you catch kids young, it's so much easier. And so you can really do either as a first line treatment. Looking back at the low glycemic, there was a pattern there. Seizure-free except for illness. Seizure-free except for illness. For whatever reason, when you get sick and you have a fever, there's, again, back to the immune system, there's inflammation, everything changes, and I think, we don't know for sure, but likely what happens is that you don't process your foods and break things down the same way you do them when you're not sick. And so the diet doesn't seem to work as well when you're like acutely feverish and sick. So if you only get sick enough to have breakthrough seizures twice a year on the diet, a lot of times what we'll do is we'll just have kind of as needed Valium ready, and you just stay on the diet, and then when you get sick, you just take it Valium for a couple of days. Hopefully it kind of wards the seizures off, and then you kind of just keep going with the diet. That's worked for some kids. Other kids, it's worked okay, but they still would go into non-convulsive status here and there. So we put them on a small dose of clobazam, and we had really good effects from that. So you can do diet as a monotherapy, as an only treatment, but the only caveat is that you just have to watch out for times of illness. So having that Valium as a backup plan, just a couple days here and there as needed, is really a good option. Meds, diets, surgery, again, don't do resective surgery. For the VNS, it's an option, but really kind of a last resort, because the meds and the diet work so well. There's usually something you can do to get them under control before you, because once it's in, it's in. You don't get that wire out. It's too dangerous to take it out. If you do start a medicine, then we've kind of identified a few that have worked really well in our 250 folks that we've tried it on. And again, Depakote is medicine so many people are on, because for years it was the only option. You look at all the literature, it's like Depakote's the best, and it was. But again, possibly because of a mitochondrial type thing, it just has so many motor side effects. Again, not everybody, and I think because there's so much variability, someone with Angelman syndrome may have just minimal mitochondrial thing, and the Depakote won't bother them at all, and others it may bother them a lot. So since we don't know who's who, we just try to not start it. But if someone's on it and doing well, we don't. Basically, the rule is if you're on something, you're doing well, don't rock the boat. But if you're not on it, then we usually try to avoid it, because there's a much higher chance of problems. And that is it. So you've seen me way too much today. Chris Carey was here earlier. Gave a great talk on anxiety. Chris McDougall is the other psychiatrist that works with us. Kristen Ganguly, our GI doctor. Heidi, all of you probably saw our talk this morning. Amy Morgan, our neuropsychologist. Ken Sassow, our sleep doctor. Amanda is our fantastic nurse back in Boston. And we'll be adding a behavioral therapist soon, Nicole Simon. So that's the crowd, and that's Mass General. It's terrifying, but it's it's enormous. But we have one little tiny room in that building over there is our clinic. But but that's as much as I could squeeze into an hour and 10 minutes of seizure. So if there's any question, I think there's probably a session starting soon, so I can always take questions on the side, but yeah. Sure. I don't think so. Is the next one at 4? Or is it 4:15? Okay, so we have a few minutes. Yeah.
What are your thoughts on, I'm not sure if you mentioned the use of medical marijuana.
Yeah.
Did you mention, I'm not sure if you mentioned the use of medical marijuana. Did you cover?
Yeah. Oh, I just really briefly. So I think I probably called it CBD. So CBD is it's the abbreviation for cannabinoids. So that's medical marijuana. So I mean, so for medical marijuana in general, there has been a trial. It was a multi-center trial in the U.S. It was through a pharmaceutical company. We actually went to sites at Mass General. The results were good. It showed that the cannabidiol was as effective, maybe a little bit more effective than most seizure medications. So there's already some good evidence that it's helpful for seizures. We don't know if it's helpful for anxiety, for sleep. It could be. We don't know. We've had some families say it's been great for certain things, others not so much. So that's something that we were looking forward to getting more data on, because it could be. The other issue is that you just can't get it really. That you can only get the pharmaceutical grade through the trial, and then it varies state to state. Massachusetts, we can get it now, so that's an option for our kids. But if you live in a state that is not legal, you can't get it. There's hemp-based oil that you can get online, but it's unclear how well that works as compared to the actual medical marijuana. So it's a big messy topic in the U.S. just because it's at the federal level, the FDA says it's Class 1, it's illegal, it's not okay. But each state has their own laws, and they say, this state says, no, it's okay, this state says, no, it's not okay. And depending where you live, you could get it or you could not get it, and it doesn't cross state lines. It's very messy. But I think that kind of the take-home message is, even though it's really hard to deal with right now, it's a very promising treatment. We don't know enough, and we need to get better access to it, but it's promising, I think.
Okay, thank you.
Sure.
Hi, my son is 5 and he has atonic seizures that have been well controlled with Keppra. And our last appointment with our epileptologist, he asked if I wanted to have him hospitalized for a 24-hour EEG to rule out ES. Could you speak to that prevalence in kids with Angelman syndrome, and is that something that you would advocate for a child that's well controlled with Keppra?
That's a good question. So ESES is a term that we use, and it varies with CSW. I see people use them both. It's basically when you don't have many spikes awake, and then half of your EEG or more at night is filled with spikes. And you don't see clinical seizures, but you see regression or developmental plateauing. That's a good question. We don't see it much in Angelman. It's something that we see all the time in autism, and I see a lot of kids with just idiopathic autism, and it's a big thing. With Angelman, it's more the non-convulsive status. And so what's nice about that is, as far as assessing it, is you just get a 30-minute EEG, you'll know. I mean, really a 5-minute EEG, you'll know. Mm-hmm. As far as getting a 24-hour, the way I do it is if there's a clear change, if development's plateaued, if there's regression, if things are just not right, then we like to kind of check and see what's going on. If things are going great, I don't torture kids with an EEG, so we do it kind of kid by kid basis. If things are going really well, we don't need the EEG, we know it's fine. If there's an unexplained regression plateau, there's no good reason, there's no bad sleep, there's no bad anxiety, it's just something's off, then they can be helpful. Okay. But if the atonic seizures are really well controlled, it's unlikely that you're seeing a bunch of spikes at night.
Yeah, that's kind of what I was going with, and we deferred on that. But Okay, all right, thank you.
Yeah. Oh, sure.
First of all, I'd like to thank you for your time that you've given today
and
for the information that you shared with us. And I think the question that I have, you've probably already answered in your presentation, but I'm from Texas and I can't listen as fast as you can talk. So
you can't what? Sorry, what?
Our son is 32 years old. He's been on Depakote since the early 90s.
Yeah.
And we kept him on it because he hadn't been having any seizures. But we started noticing some postural difficulties, and he's regressing with his walking. So as a result of what we've heard today, we would like to take him off the Depakote. But how do we go about getting him off the Depakote, and then what would be the
Yeah,
the next medication that you would recommend?
Yeah, I mean, it's definitely something to discuss with the neurologists, and that's why we really wanted to kind of get that paper published and get it in print so that whoever the treating doctor is can go online and read it. It's it's in the literature, but it's again it's with Depakote. Because of this high risk, we don't start it on kids, but if you've been on it for years and things are great, it's again, don't rock the boat. But if you're seeing symptoms that you think might be related to it, then if it's folks that we see, we typically try to take them off. But it's definitely something to discuss with your neurologist. One of the issues coming off Depakote is that it sounds weird, but it can be a sedating medicine. So if you've been on it for years and years, you may not realize that it's sedating because that's kind of the norm. So we've had some kids we've taken off of it, and they've been so much more awake and so much more alert, and just overall, because it can really kind of dull cognition sometimes, and just awake and alert and happy. And then the issue is at 3 a.m. they're awake and alert and happy. It's a sedating medicine. So when you lift the sedation, they're just up. So coming off of it, we typically do see ambulation much better, we see gait better, but just to kind of keep in mind, you're probably going to see sleep worsen, so just to kind of think of but you're better off adding a sleep medicine and getting off the Depakote and fixing the side effects than, just something to keep in mind that it probably is treating some things, but it's a lot of extra side effect for what it probably is treating, but just knowing that sleep may worsen, other things may worsen, but that they're more easily treatable.
What would be the first medication that you would recommend in place of the Depakote?
It's tough when we take adults off. If they've been seizure-free for years and years, we often don't replace the seizure medicine because a lot of times seizures will go away and stay away. But if we do replace it, we usually use one of the ones I was talking about, Keppra, clobazam. Clobazam is really good for adults because we see more anxiety in adults, and that can be one of the few seizure medicines we have that can help anxiety. So that's at least, and it's my personal kind of plan of attack, but other people might have different options. But that's what I like to do is, if I'm switching Depakote to something else, I usually do clobazam because it can have that added benefit of anxiety.
Thank you.
Yeah, sure.
Hi, my daughter Abby, she is 5, and over a year ago, she started on Ketogenic Diet. Mm-hmm. And prior to that, through the 24-hour EEG, it showed that she had over 100 seizures a day. But half a year after she started on the diet, the 24-hour EEG showed that seizure reduced to almost 0. And my question for you is, as I was listening to your talk regarding the ketogenic diet versus the low glycemic diet, I'm just wondering, why would one choose one over the other, or is there a meaningful difference in terms of the effect in reducing seizures for the patient?
That's a good question. So the ketogenic diet's a little bit more powerful. So if she was having 100 seizures in a day, that makes sense to just start with the kind of most powerful diet that we have. And it's always a hard question if it's working, do you want to rock the boat? But then at some point the decision, you gotta make the decision, okay, because if it's at the highest ratio, it's a 4-to-1, the proteins and fats to carbohydrates. But at some point, what we typically do is when things are going really well after they were really bad and it started ketogenic and things got better, you can kind of start bumping that down to a 3-to-1, to a 2-to-1, and once you start getting towards more like a 1-to-1 ratio, that's more low glycemic. So it's almost like being on if you think of it as being on like Keppra at 1,000 milligrams, it would be like dropping her to 900, then to 800. The same thing with the diet therapy, just kind of dropping that ratio a little bit. The question is when, and it's a hard decision to make. You have to look at a lot of different things, but that'll be the thought at some point is, okay, when can we start kind of coming down? But we have a lot of kids, like I said, we've had kids with Angelman now that have been on the diet for 9 years, so it's the kind of thing where, if it's working that well, you may never want to take her off. And the younger you start, they grow up not realizing what a cupcake is, not realizing what a cookie is, and they'll grab a carrot next to a cupcake because that's what they know. So it's something you could be on forever. It's just at some point the question is, does it need to be that intense? Because the more ketogenic it is, the more you have to watch for acidosis and low carnitine levels and all that kind of stuff, and the more likely you are to have constipation or reflux. So at some point, kind of cutting it back, but it's a tough choice to know when, but that would probably, that's probably what we would do at some point when everyone was comfortable, start cutting it back a little bit, but then maybe recommending not coming off it for a while, because if it helped that much, and we do see it help that much, it's such a healthy diet. And when kids are on diet therapy, they tend to be more focused, they tend to be more alert, and so if she's doing well with it and she's tolerating it, I would just stick it out. I know Heidi would say that.
Okay.
And but the question is, does it need to be that hardcore? Can you kind of back it down to low glycemic? And the answer is maybe. The question is when.
Does the ketogenic diet have more side effects than the low glycemic diet?
Because you have more fat and you're kind of going more into ketosis. It's not that it has more. It's just you have to monitor more closely. There's a higher risk of ketosis, higher risk of acidosis, a higher risk of all these different things, constipation, reflux. The more fat you're taking, the more risk there is. If that's all really well controlled, it's okay. But at some point, it's just a little bit safer and easier to cut back. Would you have anything? Yeah, Heidi agrees.
Thank you.
Sure. Yeah, we probably have time for a couple more.
You've been staying longer. Go ahead.
My niece hasn't had seizure medication in decades. However, she is in need of dental surgery, so we're concerned about any possible seizures that might come up, and would like to know about how to any interactions with anesthesia or surgery that might.
That's a good question. So we typically don't see a big issue with anesthesia and with surgeries. Is she on diet therapy or just not anything? Yeah. So I think the key would just be to what we tell people is just to be extra careful, not kick them out of recovery too soon. Just really monitor closely. For some people, if they're really worried, but you can always do a little bit of, especially if they get a benzo during the surgery. You could always do a couple days of like a Valium taper, just so that whatever kind of benzo they get during the surgery, instead of just getting a big dose and then stopping it, you take a little bit for a couple days. But that's probably not necessary, but that would be the cautious route. But we really don't see, like with metabolic issues, mitochondrial issues, that's a big deal to get anesthetized. But with Angelman, we really don't see much. So it's typically not an issue.
Thank you.
Yeah. If you're on dietary therapy, then you have to make sure you remind people, don't put glucose in the IV, don't give the D5 like that, because then you'll just ruin everything.